So if you think back to last week, we finished up talking about breathing and the factors that are involved with that, which really relates to what you just had your exam on, talking about pressure gradients, where high pressure must be created in one area related to another for the flow of air to occur, just like with the flow of blood. The very last stuff that we were talking about was airway resistance, which is similar to vascular resistance. Instead of the opposition of the flow of blood, airway resistance is the opposition to the flow of air. And that's something that affects breathing, okay? Well, let's now talk about pulmonary volumes. While at rest, a healthy adult averages 12 breaths per minute. So that's kind of like your heart rate, except it's your breathing rate. Very significantly less in number than your heart rate, roughly around 60, 70 beats a minute. That's what our heart does. We're only taking about 12 breaths per minute, okay? And that's with each inhalation and exhalation moving a specific volume of air into your lungs, okay? A device known as a spirometer is used to measure the volume of air that can be exchanged when one breathes. Very commonly used in clinical settings. Anymore, you go to the doctor and you have to use the spirometer. It's going to be all electrical and very precise in measurement. There's some other methods to do it. I have one that I used to use in the lab, big old structure where you have to fill it with water and blow into the tube that connects to this drum that lifts up with the air that fills up the drum. And it's really complicated, but most barometers anymore are very precise machine hooked up to a computer. So very, very good at calculating these different measurements, okay? The first type of spirometer measurement is tidal volume, abbreviated TV for short, which makes sense. Volume of air exhaled normally after a typical inspiration. So it's either, you could say it's the amount of air that you exhale after you just normally breathe out, or it's the amount of air that you normally breathe in. Okay, so everybody take a quick inhale and then a quick exhale. And just a normal breath in, a normal breath out. That's your tidal volume. And they call it tidal volume because if you measure it using a spirometer, it's like the tide in the sea where you breathe in, you breathe out, you breathe in, you breathe out, you breathe in, you breathe out, you breathe in, you breathe out. And so it's going to flow like the ocean does with the tide. Okay. It's about 500 mils, which is about half a liter. About 70% of that actually reaches the respiratory zone. So it is going to be able to go through gas exchange, about 350 mils, which leaves about 150 mils, or about 30% that remains in the conducting zone, which, if you remember, conducting zone is the airways basically above the lungs and some of the bigger parts of our bronchial tree, and therefore does not undergo respiration. So that portion of our respiratory system, that portion of the conducting zone, is often referred to as the anatomical or respiratory dead space, which is kind of misleading. Obviously, it's not dead tissue, but that air that remains in those places does not really service any purpose because it just gets exhaled back out, because we never end up allowing for gas exchange to occur. Expiratory reserve volume, or ERV, is the largest additional volume of air that a person can forcibly expire after expiring their tidal volume air, and is about 1,200 mils in males, a little over a liter, and just under a liter, 700 mils, or 0.7 liters in females. Okay, so you could do this, just take a normal exhale out, and then after you get that little bit of air out after that normal exhale, then blow off everything that you have left. That's what your ERV is going to be. Okay. Basically, the opposite of that is your inspiratory reserve volume, which is the amount of air that can be forcefully inspired over and above a normal inspiration, and is a significant amount of air, especially in males, over 3 liters in males, 3,100 mils, almost 2 liters or 1,900 mils in females. So if you take a normal inhale and then you suck in as much air as you can, that amount of air that you can suck in at that point is your inspiratory reserve volume. And your residual volume is the amount of air that cannot be forcefully expired. So it's the amount of air that's left in your lungs after you've maximally expired. So after you huff and puff and blow, everything that you feel like you can blow out of your airways is blown out. Truly, there is still some air in your lungs, which is fantastic, because then it allows for exchange of oxygen nutrient or oxygen and carbon dioxide to occur between the residual air and your alveoli. So we're still performing gas exchange between breaths. Okay. Now I'm sure you've all had that experience of getting the wind knocked out of you before, and it feels like you've pushed all that air out and you can't fill your lungs back up. It's not like you've actually gotten rid of the residual volume. That is not what's actually happening. When you get the wind knocked out of you, it's actually because the diaphragm, which we talked about the other day, the muscle that allows you to breathe in and out, is undergoing spasms because it's like taking a direct hit. So not a fun experience, but typically only lasts a little bit of time. Residual volume is about 1,200 mils in males and 1,100 mils in females. As far as knowing the amounts, you don't need to worry about that. Okay, I had to learn them when I took a class, but that was not basic human physiology. That was an upper level class. It was respiratory physiology. So it was actually when I was in grad school that I had to learn all that as far as the numbers go. All I care so much about is you just knowing what those 4 volumes are. So know that tidal volume is the volume of air exhaled after a typical inspiration, and so on and so forth. Make sense? Okay. Now you can use those volumes and you can add them together to calculate what we call pulmonary capacities. And there are 4 of those. Some of them you just add 2 things together. Some of them you have to add several more together. And I didn't include the values for this, and that's okay. Like I said, for the volumes, you don't need to worry about those. Okay, the first capacity is vital capacity, represents the largest volume of air an individual can move in and out of their lungs, and is equal to your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume. Okay, so in other words, it's everything with the exception of your residual volume. Okay, it is expiratory reserve volume, tidal volume, inspiratory reserve volume, all those added together. Okay, inspiratory capacity, IC, is the maximum amount of air an individual can inspire after normal expiration. So after you take an exhale, it's as much air as you can suck in. So it's your tidal volume, which is what you breathe in normally, plus IRV, the amount that you would breathe in after you've taken your normal inhale. Okay. Functional residual capacity is the amount of air in your lungs at the end of a normal expiration. So if you take a normal exhale out, what's left in your lungs at that point is your functional residual capacity, or FRC, and that's equal to ERV plus RV. And then total lung capacity, exactly what it sounds like, total volume of air a lung can hold. So it's your residual volume, your expiratory reserve volume, tidal volume, and your IRV, inspiratory reserve volume, all added together. And that's all illustrated here on this page. As far as, like I said, for the volumes, you don't need to know the numbers. Don't worry about the calculation. You don't need to worry about the formula. You don't need to worry about actually doing any calculations. Just know the definitions of each of these. And now those are used in many cases as a measurement of your lungs function and your airway function. Okay, along with another test, which we'll talk about on this page. So spirometers can be used to do other things aside from measure those 4 different volumes. It can also be used to calculate your total minute volume, which is the amount of volume of air moved per minute, which is really not super helpful. That's kind of like cardiac output, except instead of the amount of blood you're pumping in a minute, it's the amount of air that you're breathing. Okay. Much more of a clinical test that's very beneficial is measuring the forced expiratory volume, or FEV for short, which is the volume of air forcibly expired during different amounts of time. Okay, and essentially they use 3 forced expiratory volume times. FEV1, which is the amount of air that can be forcibly expired after 1 second, FEV2, which is after 2 seconds, and FEV3, which is after 3 seconds. It's FEV1 that's really the most beneficial. Okay. Now, I grew up with asthma, so I went to a special doctor every few months, and I specifically remember doing this test. I didn't know what it was at the time because I was a kid, but I still remember it to this day. Okay. It was a pretty easy, straightforward test for a kid to do. I just remember the doctor or the nurse that was performing it told me to take a deep breath in as much as I could, breathe in, breathe in, breathe in, breathe in, and then blow out as fast as you can, as hard as you can. And for somebody with good open airways, somebody with asthma does not have good open airways, but somebody with good open airways can suck in a whole bunch of air and then blow most of that out in 1 second. Okay, it means that the air is flowing out very, very rapidly, and they almost draw all that air out immediately within 1 second. But somebody with chronic obstructive pulmonary disease, COPD for short, look at the amount of air that they are able to exhale after 1 second compared to somebody that has a normal FEV value. Even after 2 and 3 seconds, they are still not blowing off nearly as much air as the person with a normal airway did after 1 second. So it's almost like they're blowing all the air out through a straw, whereas somebody else is blowing the air out, out of their full big mouth and their full big airways. Okay. So I remember this test. Actually, my sister was just a couple years younger than me. We'd go to the doctor because she had it as well. So we had to travel to Topeka to do it. So we'd always schedule our appointments on the same day. I remember competing with her at this, and I sucked at it worse than she did. So that broke my heart. So, like I said, FEV1 is a very clinical or clinically useful test, especially when looking at those with obstructive disorders. There's kind of 2 major airway type disorders, restrictive and obstructive. Restrictive disorders are those that cause an abnormally low vital capacity, which, if we go back to vital capacity, so that's the largest volume of air an individual can move in and out of their lungs, and it was equal to essentially everything except for their residual volume. Okay. Whereas obstructive are those that cause an abnormally low FEV1. So COPD, which was shown in this graph, is an example of an obstructive disorder. Okay. COPD, short for chronic obstructive pulmonary disease, is a disorder characterized by chronic and recurrent obstruction of airflow, increasing airway resistance. So in other words, their airways are a little bit tighter and more narrow. And actually, people with COPD are not just obstructive. Those with it are going to be struggling with restrictive issues. Okay, so they're going to have a low vital capacity and a low FEV1. Okay, 2 primary types of COPD are bronchitis and emphysema. Mentioned a little bit about emphysema last week, but bronchitis occurs when a patient produces excessive tracheobronchial secretions, where essentially there's too much mucus that blocks their airways, and therefore the air can't flow through very nicely. We can see that very easily here on the next page. Whereas here in figure D, we show emphysema. Those are the little grape-like alveoli I talked a little bit about last week. Okay. Emphysema occurs when the airspace is distal to the terminal bronchioles enlarged as a result of damage to lung connective tissue. People with emphysema contain abnormally large air spaces in the alveoli that remain filled with air during exhalation. And that's why they can't exhale their lungs. And therefore, and I talked about this the other day, people with emphysema have big barrel chests is one of the descriptions. So it looks like they're always puffing out their chest. It's because their lungs aren't able to deflate. They're not able to blow that air out very well. And so they suffer from that issue. Asthma, as you can see on the bottom left there, is characterized by chronic airway inflammation, airway hypersensitivity to a variety of stimuli. So in other words, their airways are like essentially allergic to different things, okay? And they have airway obstruction as a result, okay? And what can happen during people with asthma, especially during an attack, as they describe it, the smooth muscle will spasm in the walls of their smaller bronchi and bronchioles. So they pinch shut, which we can see here in our picture. They also will see edema of the mucosa airways. So there's swelling in the airways. The mucosa is the lining of those airways. So the airways get a little bit clogged up because there's swelling in there. There's increased mucus secretion, which you can see as well in the figure. And then there's damage or could be damage to the epithelium of the airway. So that's what people with asthma suffer from. So a lot of it in people is a result of hypersensitivity, which, as we learned just recently, is a kind of fancy word to say allergic. So people with asthma, they have like an allergic reaction, but it's specific to like their airways, and therefore that's what causes like an attack. And for me, it's like when I'm around cats, you know, I'm allergic to cats really badly, and so that's like when I get really wheezy. I'm pretty good other than that. Over on the right illustrates a table talking about respiratory rhythm. So we kind of talk a little bit about breathing rate. We'll talk a little bit more about later in the lecture. Some of these terms you might have seen before, like apnea, you may have heard of before, is a temporary cessation of breathing. So in other words, it's like your breath, you actually like lose your breath. You guys ever heard of sleep apnea before? People with sleep apnea, they literally stop breathing in their sleep. Like if you jump in a cold pool and you know the phrase, it took my breath away, it actually will take your breath away. It'll cause a quick apnea. Dyspnea, this is just labor breathing or being short of breath. So like when you're exercising really hard and you feel like you can't catch your breath, you're just experiencing dyspnea. Okay. The two that we'll talk about the most in this lecture are hyperventilation and hypoventilation. Hyper and hypo, we've seen those prefixes a lot this semester, mean high and low. So hyperventilation means an increased breathing rate, in other words, and hypoventilation means it's slower than normal breathing rate. And we'll talk a little bit about that and how we can alter our breathing rate, either speed it up or decrease it in order to affect our pH, since that's an important thing. All right, other respiratory disorders can involve oxygen imbalances. Notice we have hypoxia listed here 3 different times, which we've talked about before. Back as recently as our blood lecture, when we talked about the formation of red blood cells, learned that hypoxia is a stimulus for making more red blood cells. There's actually several types of hypoxia. Hypoxia is a state of low arterial PO2. In the case of hypoxemic hypoxia, it's usually due to inadequate pulmonary gas exchange. So in other words, we're not getting enough oxygen from the lungs into the alveoli. And this can happen like at high altitudes or high elevations, or just by having an impaired ventilation. So like in the case of somebody not breathing correctly, so could be because of asthma or bronchitis or something like that. Ischemic hypoxia, the word ischemic or ischemia always refers to a decreased ability to circulate blood. So people with ischemic hypoxia are having hypoxia, but it's specific because of their inadequate ability to circulate their blood. And then anemic hypoxia, anemia is a decreased ability to carry oxygen in the blood. So essentially anybody that's anemic is more likely to be hypoxic as well. And it's because of the fact that they can't carry the oxygen in their blood. Okay, so let's move on from that. And we can now talk about our alveoli. And I mentioned those the other day. Alveoli are the primary structure for gas exchange of the respiratory tract, performing what we call pulmonary or external respiration. This is where we exchange carbon dioxide or CO2 and oxygen. O2 enters the blood, CO2 leaves the blood. Closely associated with alveoli are alveolar ducts, which we can see one of them labeled here in the picture, but there are a couple others illustrated as well. They are just airways that lead from the bronchioles, which would be what this is, a terminal bronchiole there, to the alveolar sacs. And an alveolar sac, once again, I told you this the other day, is like a cluster of grapes. And an alveolar sac has a common opening with all the alveoli. So one alveolar duct carries air to all of the alveoli in the cluster. Okay. Now, each alveolus, that word alveolus is singular, is only one cell thick. We can see its situation here in a couple of slides. We'll get to this picture and talk a little bit about it in a second. But by having only one cell layer that forms its wall, it's very thin walled and thus is really, really great at performing gas exchange with very little resistance. And that's fantastic. We want these walls to be as thin as possible so that it's easy for oxygen to pass through and CO2 as well. O2 leaving the alveoli to enter the capillaries and CO2 to leave the capillaries and enter the blood. Okay. Now this illustration is great in that it shows those structures. I do kind of see some drawbacks to the picture. You can see the capillaries very nicely with this alveolar sac, but you don't see them associated with these. I guess they just simplified the image. Keep in mind, what you'll find is every single one of these alveoli has a very dense network of pulmonary capillaries surrounding it. Okay? And keep in mind, once again, our lungs are not hollow structures like a balloon, but they do have millions of these alveoli, which are like the little tiny balloons of our lungs. And your lungs are a lot more like a sponge and not like an empty balloon sac type structure. And by having millions of these, it increases the surface area of each lung, which is great because the more surface area, the more gas exchange. Now, speaking of gas exchange, that involves what we call the respiratory membrane. This is a barrier across which gases are exchanged. It is a 4-layered membrane, which sounds like there's a lot to it, but it is absolutely, at least in a normal healthy lung, very minuscule. Okay. Looking here at the illustration on the next page, here we're showing the interior of one alveolus. Okay. The wall of an alveolus, we've already said, is one cell layer thick, and the cells that form its wall are called type 1 alveolar cells. Now they have another fancier name, but type 1 cells, what I will call them, they are simple squamous type cells, meaning that they are flat, and there's only one layer of them. Okay. Just like the endothelial cells that form our capillaries that we've recently talked about, which were very thin and one layer thick. Now, if we zoom in at the junction where a type 1 cell and a capillary are, we can see those 4 layers that make up the respiratory membrane, okay, which is what this is circled and showing here. This is what must be crossed in order for oxygen to enter the blood or CO2 to leave the blood to enter the alveolus. Okay. The 4 layers include the type 1 cells. Surrounding it is a thin basement membrane. Then you've got the capillaries, flat plate-like endothelial cells, and its basement membrane. Together, those 4 layers make up the barrier for the diffusion of oxygen and carbon dioxide, which sounds like it's a lot because there's 4 layers, but I'm telling you, in a normal healthy lung, it is fractions upon fractions upon fractions of anything. It is extremely, extremely thin walled, and therefore is a very, very small resistance to the flow of oxygen and the flow of carbon dioxide, which is great. That's what we want. We want as easy of a time to get oxygen in the blood and easy of a time to get oxygen or CO2 out of the blood into the lungs. Okay. Now, aside from the type 1 cells, we will find within our alveoli type 2 alveolar cells, or type 2 cells, go by septal cells, and they produce a very important fluid called surfactant, which is on the inside of each alveolus. Okay? And surfactant is important because it reduces surface tension, which is the force of attraction between water molecules. So it reduces the surface tension of the fluid. It prevents each alveolus from collapsing and sticking together during respiration. And in doing so, these two things really impact number 3, which is what the whole importance is. And that's that surfactant allows oxygen to diffuse more easily. And so that's a very, very important fluid. And it's produced by those type 2 cells. You'll also find macrophages within the alveoli that can clean up any dust particles and other stuff through phagocytosis. You'll find some other cells kind of sprinkled around, but it's mainly the type 1 and the type 2 cells that are part of the alveoli. So now that we know the structures involved with gas exchange, we can start getting into the fun stuff and learning about gas exchange. All right, if we go back several slides, actually back from what we talked about on Thursday last week, when we described ventilation and breathing, okay, we learned just briefly that inspiration occurs when atmospheric pressure, or P sub B, is greater than alveolar pressure, P sub A. Okay, the P is short for pressure, B is short for barometric. In this case, P is still short for pressure, and in this case, A is short for alveolar. Okay, well, the thing I want to talk a little bit about more now is atmospheric pressure, the pressure in the air around us that we're breathing. Okay, where does that come from? Okay, well, the total pressure produced by the atmosphere is the sum of the pressures produced by each of its gases. In other words, the air that's around us, the pressure in that air is due to all the pressures of all the different components of the air. In other words, there's not just oxygen in the air. There's not just carbon dioxide in there. There's other gases as well. And in fact, nitrogen is the main component in the air that we breathe. And it's significantly the highest amount. It is almost 79% of the air that we breathe. Okay, whereas oxygen is only roughly just under 21%. Carbon dioxide is very, very minuscule in the amount of in the air that we breathe, and not even a singular percentage. Okay, so you essentially add those gases up together, primarily oxygen, nitrogen, and carbon dioxide, and that's what gives you your barometric pressure. Okay, this table down here at the bottom shows you how we get that 760 millimeters of mercury at sea level. Okay, which would sea level be right, on the beach, staring at the sea, where it can actually walk up and hit you on the feet when the tide comes in. Okay. Well, each gas in the mixture exerts its own pressure as if no other gases were present. And we define this as Dalton's law. The other day we talked about Boyle's law. This is our second law of the lecture, Dalton's law. It's not our last one. Okay. We can calculate how much pressure each gas exerts if we know the barometric pressure. You can't literally measure the pressure of oxygen directly, nor can you measure the pressure of nitrogen. But you know the percentages. What you can measure is the barometric pressure using a barometer. Each of those gases exerts its own what we call partial pressure. Pressure exerted by any one gas in a mixture of gases or liquid. Okay. So looking at this table, we can calculate the pressure of nitrogen, which I said was just under 79%. So converting that to a decimal, move the decimal to the side 2 times to the left, 2.786. You times that by 760 millimeters mercury. The pressure of nitrogen in the air at sea level is 597.4 millimeters mercury. At sea level, calculating oxygen, you take 20.9% or 0.209 times 760 millimeters mercury, and you get 158.8 or roughly 159 millimeters of mercury. Okay, you can add up all those different gases, and that's what gives you 760 millimeters of mercury. Now, is this number of 760 the same no matter where you're at here on Earth? Is the barometric pressure the same in New Orleans, which is actually a little bit below sea level in spots, as it would be like in Breckenridge? Does that number go up or go down when you go to higher altitudes? It goes down. There's less pressure. Okay. Now, I'm sure you've all heard that, you know, when somebody goes to Colorado, which is a fairly common thing, we're not too far from Colorado, going there this summer, that there's less oxygen in the air. Probably have heard people say that before. That's not true. What is true is there's less pressure of oxygen. This 20.9%, 20.93 to be specific, that's the same here in Kansas as it would be at the top of Mount Everest. It would be the same below sea level in New Orleans, okay? But this number drops the higher up in altitude you go, which means the pressure of oxygen goes down, which affects how much oxygen ends up in our body. Because each gas diffuses across a permeable membrane from the areas where its partial pressure is greater to the area where its partial pressure is less. Okay. What that means is the higher the pressure of oxygen, the easier it is to get it into our blood, and the easier it is to get it into our cells. Well, if this number is lower, this number is lower, which means less oxygen can get into our blood, less oxygen can get to our cells, less energy that we can form. Therefore, you might experience, you know, lightheadedness and stuff like that. Or if you're, you know, doing something physically active, your ability to do it at a higher level would be drastically reduced. That's why they don't hold like the Olympics at high altitude anymore. Back in, I think it was the 80s or 70s, they had the Summer Olympics in Mexico City, which is pretty high in altitude. And all the people that didn't come from places in high altitude really got their butts kicked because they weren't used to it. Their ability to perform was drastically reduced. So, and it's because of this right here. The greater the difference, the faster rate of diffusion. And so this is a misconception. Somebody tells you there's less oxygen in the air in Colorado, you can tell them they're an idiot. You can tell them that there's a less partial pressure of oxygen, then you'll be talking. That affects this law, Fick's law of diffusion. Fick's law of diffusion states that the amount of gas that moves across a sheet of tissue is proportional to the difference in gas partial pressure, or the pressure gradient between the two sides. So in other words, the bigger the difference between the two sides, the better diffusion occurs because it's proportional. It's proportional to the tissue area, which we just learned. Our lungs have a very high surface area because of the fact that they got millions of alveoli in our lungs. However, it's inversely proportional to the tissue's thickness, which is what these two illustrations are showing you. Okay. Remember, I was just talking about the respiratory membrane, which is the 4 layers between our blood and our alveoli. Okay. In a normal healthy lung, this is what it's like, where that wall is very thin. Those 4 layers are minuscule, and so oxygen can easily diffuse. So this would be oxygen coming into the red blood cell. CO2 would be going in the opposite direction in the alveoli. This is what can happen in diseased lungs. Okay. What we call pulmonary edema is swelling in the lungs. A little bit of fluid can get in those spaces between the two membranes, and thus the distance to go into the blood or out of the blood becomes significantly higher. It's a bigger distance. And since it's inversely proportional, the bigger the thickness, or the higher the thickness, the less diffusion can occur. Does that make sense? Think of it, if you can walk 2 steps, or if you can walk 200 steps, what's going to be easier? 2, right? And this is like walking 2 steps is like walking 200. Now, last week, we learned that the process of respiration involves 5 different things. Let's just go back and reiterate what those 5 things are. Okay. The first, what we talked about last week, was breathing. The second, pulmonary gas exchange, what takes place in our lungs to get oxygen into the blood and CO2 out of the blood. The fourth, I'm going to skip the third one. We'll talk about the transport of oxygen, carbon dioxide in the blood, but we'll wait and talk about that after we talk about systemic gas exchange, which is where we do the opposite of what we do in the lungs. We take O2 from the blood and move it into our cells. We move CO2 from the cells into our blood. Okay. So number 2 and number 4, gas exchange. Let's talk about those. First, we'll talk about alveolar gas exchange, or what we call external respiration. This is the back and forth movement of O2 and CO2 across the respiratory membrane, in other words, between our alveoli and our blood, and is affected or dependent upon several factors. Okay. The partial pressure gradients, which is what I was just talking about, is very important. PO2, that abbreviation there is short for the pressure of oxygen. So we saw that actually on this page here with our table. The partial pressure of oxygen at sea level is about 159. Okay. In our alveoli, PO2 is about 104 millimeters of mercury. It's about 40 millimeters of mercury in our pulmonary capillaries arriving at the alveoli. 104 is significantly higher than 40, correct? So where's it going to go? Oxygen from high to low, and therefore oxygen is going to easily diffuse from our alveolar air into the blood, okay, which is shown right here. Okay. Now, this is all dependent upon what the atmospheric pressure of oxygen is, because like I said, if we go to high altitude, PO2 is going to get lower, which therefore is going to make the alveolar PO2 go down, and thus there's less of a drive to get that oxygen into the blood. Whereas here at sea level, or close to it anyway, I don't know if Kansas is quite sea level, we're pretty darn close, especially on this side. Alveolar air PO2 is roughly 105. The PO2 of the blood that's coming into the lungs is at 40. That's a 65 millimeter mercury difference, so oxygen is going to easily diffuse into the blood. Okay. Diffusion distance. Respiratory membrane is very thin, so diffusion occurs quickly. Also, capillaries are so narrow that red blood cells must pass through them in single file, minimizing diffusion distance from alveolar airspace to hemoglobin inside the red blood cells. So not only is it important to get the oxygen into the blood, it's also important to get the oxygen into the red blood cells, because that's where the hemoglobin is. Okay. I've already described it this way, but the respiratory membrane is essentially an obstacle for diffusion to occur. But in a normal healthy lung, it's very thin, about 0.5 microns or 0.0005 millimeters. I mean, that is, I don't know what paper thin is, but probably around that, maybe not even that thick. And so diffusion distance shouldn't be an issue in a healthy lung. Membrane surface area, as we've already talked about, in good health, each lung has about 70 square meters of respiratory membrane available for gas exchange. Okay. That's incredible how much membrane is available for gas exchange. However, that's a normal healthy lung. Several pulmonary diseases can decrease the surface area and thus lead to decreased ability to diffuse oxygen. That's weird. Ventilation and perfusion coupling relates to the body's ability to match ventilation or air availability and perfusion, which is a fancy term for blood availability, to each other. Okay, so think of it this way. We need to get oxygen from the lungs into the blood, right? Well, if we're not delivering blood to the lungs, what's the importance in breathing? And we have to get those things to match up. Okay. Well, in a normal healthy situation, that shouldn't be an issue. So that's not a problem. Like I said, in health, good health, that is. And then the solubility of the gases. Gases differ in their ability to dissolve in water or blood. Okay, but thankfully in our blood we have hemoglobin, which increases the ability of our blood to carry oxygen. When oxygen is bound to hemoglobin, we describe it as oxyhemoglobin, or HbO2 for short. Okay, whereas deoxyhemoglobin, or HHB for short, is hemoglobin with no O2. I like to describe the relationship between oxygen and hemoglobin like a piggyback ride, because that's what hemoglobin does for oxygen. Okay, oxygen jumps on, catches a ride from point A to point B, and it jumps off when it gets to point B. Okay, like if you're giving somebody a piggyback ride, across the room or something like that, they hop on. That's like oxygen hemoglobin forming oxyhemoglobin. And then when the person gets off, that's deoxyhemoglobin, when the hemoglobin no longer has the O2 bound to it. Now, here's a demonstration of the importance of the partial pressure gradient with regards to oxygen diffusion. Okay, looking at this graph, it's kind of confusing, so let me kind of explain it. Measuring here in the y-axis, the ambient PO2, so the pressure of oxygen and the air the individual's breathing. Okay, whereas down here at the bottom, we're measuring the pressure gradient of oxygen. Okay, let's start right here, right around 158, 159. The pressure of oxygen in our alveoli at sea level. Okay, the steeper this line is, the easier it is for oxygen to get into the blood. Okay, we want the steeper the line, because the steeper the line, the better it is at performing diffusion of oxygen. Okay, well, it's kind of backwards, but if you go to high altitude, say 3,000 meters or 10,000 feet, we drop down. And that's because the PO2 at higher altitudes, we said, is lower, right? Is this line as steep as this line? No, this line is steeper. Think of it like, if you put a ball here and roll it down the hill, or a ball here and roll it down the hill, it's steeper here, the ball's going to roll faster. The ball rolling down the hill is the oxygen entering the blood. Okay, this is why it is said that there's less oxygen in the air at high altitude. It's not true, okay, but there's a reduced ability to, or slower ability to diffuse oxygen. And if you keep climbing, like at the top of Mount Everest, the PO2 up there is just about the PO2 at the blood coming into our lungs. So a very subtle difference. There's almost no slope to the graph, no slope to the line. Therefore, diffusion of oxygen is really, really slow. And that's why people that climb the top of Mount Everest, some don't ever make it, and they die. And unfortunately, unless your family can afford to buy a helicopter to get your body, the people that are up there aren't going to be able to carry you down, because walking 50 meters with a pack on by themselves is difficult, let alone carrying somebody. So very unfortunate situation, but people that climb Mount Everest aren't probably, a normal breed. Now, on the opposite end of the spectrum, you can drive ambient PO2 up by hopping in a hyperbaric chamber, where you can drive the PO2 up around there at 2,500 millimeters of mercury, and then that creates an extremely steep gradient and easy rapid oxygen diffusion into the blood. So that's what is illustrated there. Okay, so that's pulmonary gas exchange. Let's talk about systemic gas exchange. What also is described as internal respiration, which is essentially the exact same thing we just talked about, except now we're unloading O2 and loading CO2, and this is all occurring in our systemic capillaries. So out in the tissues of the body, whether it's in the brain, in our skeletal muscles, in the liver, whatever. Okay, and this time we want the PO2 to be higher in the blood than it is in the cells. So PO2 in our blood is higher, around 100 millimeters of mercury, than the PO2 of our tissues, about 40. 100 is higher than 40, so that allows oxygen to diffuse out of the capillaries into tissue cells, and blood PO2 drops to 40 millimeters of mercury once the blood exits it. While O2 is diffusing out of the system and capillaries, CO2 is diffusing in the opposite direction. Because tissue cells are constantly producing CO2, PCO2 of our cells is around 45 millimeters of mercury, and that's higher than the systemic blood, which is around 40 millimeters of mercury. Now that's only a 5 millimeter mercury difference, but it is enough to drive CO2 out of the cells, into the interstitial fluid, and then into the systemic capillaries until the PCO2 in that blood increases to 45 millimeters of mercury. Now the rate at which we perform systemic gas exchange is dependent upon those same factors. So the gradient, the diffusion distance, all that wonderful stuff that we just talked about. Okay. This illustration on the next page, which I've already kind of pointed out once, shows you both forms of gas exchange. Okay. Let's just walk through it. I'll start with oxygen. Once again, at sea level, we're assuming we're at sea level. The PO2 in our atmosphere is 159 millimeters of mercury. So it's easy to get that oxygen into our lungs, which drives the PO2 of our alveolar air up to 105. Here's the blood coming into the lungs with the PO2 around 40. Oxygen is going to easily enter the blood, which the more oxygen that comes in, the more PO2 will be in our blood, which is why we see over here this oxygenated blood now has a PO2 of 100, because the oxygen has come in, there's more oxygen exerting its pressure, and so the arterial side has a PO2 of 100 millimeters of mercury until that blood comes to our capillaries in the systemic circulation. 100 millimeters of mercury for the PO2 here. PO2 in the cells that are going to use that oxygen is low, only 40. So the oxygen readily diffuses out of the blood into our into our systemic tissues. Okay. Well, let's look at CO2. Now we want to drive it into the blood. The PCO2, pressure of carbon dioxide in that same arterial blood, is around 40. In our tissues, where we're constantly producing it, it's going to stay above 40, around 45. 45 is higher than 40, so CO2 enters the blood. Okay, that drives the PCO2 of that blood up to 45. Once that blood comes into our lungs, 45 is its PCO2 in the alveoli, it's 40, so the CO2 leaves, the blood enters the alveoli, and 40 therefore is higher than 0.3, so that then forces the CO2 out of the body altogether. Now, once again, keep in mind, this is at sea level, and this is all in a healthy lung. If somebody has reduced lung function, or if they're at higher altitude, these numbers can change, which can drastically affect the amount of oxygen in our blood, amount of CO2 in our blood, amount of oxygen that makes its way into our cells, amount of CO2 that would build up in our blood and can result in issues like acidosis, which we'll talk about acidosis and alkalosis towards the end of the lecture. All right, I'm going to stop here. We're almost out of time, and it doesn't make sense to start this next slide. This is another kind of important transition point. So we'll stop here, and we'll start fresh on Tuesday, which we won't see you guys once again for another week. So we'll start with this on Tuesday next week and go from there.